Hello guys, today we will talk about anomalies in the genitourinary system. This presentation prepared by me and Dr. Shevchenko. Um, Congenital anomalies. Un momento, per favore. Congenital anomalies of the kidneys and the urinary tract are relatively common birth defects. The combined prevalence in Europe was 3.3 per 1,000 in 2012. The risk factors for these anomalies are not clearly identified. Congenital anomalies of the kidneys or lower urinary tract may lead to various diseases and can be diseases by itself. And you see in the pictures any type of anomalies. Hypoplasia and dysplasia, agenesia when we haven't got one kidney, multicystis dysplasia when kidney have form of many small cysts, posterior urethral valves when we see this type of urethra. Yeah, there you see a normal type of urethra, and there you see posterior urethral valves. There you see vesico-urethral reflux when urina go behind to the kidney. Duplex collection system when we see two cup system of kidney. Uretro-pelvic junction obstruction when there we see a not normal type of urethral. Yeah, we see some obstruction there. And primary megaureter when we have a big ureter. Okay, there we see congenital and acquired anomalies of kidney and ureter, and you see a table with many types of anomalies. There is supernumerary kidney. There is usually one extra kidney, but cases of multiply extra kidneys have been reported. The supernumerary kidney has its own blood supply and capsule is usually smaller, less functioning, and in a sort of case is associated with other pathological changes. For example, hydronephrosis or pyelonephritis. Many cases remain asymptomatic throughout life and are picked up incidentally on ultrasound. When complications occur, these are generally correlated with obstruction or infections and presence with typical symptoms of pain, abdominal mass, or fever. Renal Arginesis results from a failure of induction of the metanephric blastema by the ureteric bud. Hypertrophy of the single contralateral kidney occurs. Also, hyperfiltration may have an adverse effect on renal function. The risk of significant renal disease is low. Annual urinalysis for proteinuria and blood pressure check is reasonable. Bilateral renal arginesis, called Potter syndrome, The incidence of bilateral renal arginesis was originally reported by Potter. Diagnostic on fetal ultrasound, around 40% of the infants are stillborn and in the remaining alone with absent renal function. Oligohydramnios has caused severe pulmonary hypoplasia. A characteristic facial deformity occurs because of the lack of growth and development. The prognosis is poor and the majority will die within 24 hours of being born. In cases of early antenatal diagnosis, termination of pregnancy is recommended. There we see a fetal kidney faces, its hilum and pelvis anteriorly, and during ascent undergoes a 90 degrees rotation to achieve its final normal position where hilum and pelvis face medially. Different types of anomalies of rotation are described. First, incomplete rotation. It's the most common, and hilum faces anteriorly. The second, hyperrotation with hilum dorsal or lateral. Third, reverse rotation. Hilum faces lateral and renal vessels. Cross the kidney anteriorly. And fourth, malrotation is more frequently associated with ectopic or fused kidneys and is incomplete in its commonest form. Usually it is an asymptomatic condition, and when symptoms occur, those are generally correlated with a degree of obstructions and hypernephrosis. Anomalies of ascent. Anomalies of renal ascent and fusion occur at 6 to 9 weeks of gestation. As the kidneys seem to ascend when in fact the embryo is growing caudally. The kidney is generally abnormal in position because of insufficient or contralateral ascent, classic form of renal ectopia and crow's kidney, or because of excessive ascent, thoracic kidney, much rarer. And on CT scan you see that kidney location is behind diaphragm. Anomalies of fusion. In outer, it's called Horseshoe Kidney. In Horseshoe Kidney, or HSK, Horseshoe, the two lower poles of the kidney are joined in the midline by tissue called the isthmus. The result of the Horseshoe Kidney lies Horseshoe Kidney lies lower at L3, L4 compared to the normal anatomical position because the isthmus is unable to ascend past the inferior mesenteric artery. The calyces are normal in number, however, they are abnormal in position with calyces pointing posteriorly. The blood supply is often abnormal. Management. 60% of patients remained asymptomatic for 10 years after discovery of HSK. The most common operation required for HSKs is pyeloplasty for PUG obstruction. This can be difficult if the renal units have not completed the ascent. Both extraperitoneal and transperitoneal approach are feasible depending on specific anatomic characteristics. The laparoscopic approach is used. Crossed renal ectopia. In crossed renal ectopia, the kidney crosses the midline while its ureter maintains a normal ipsilateral insertion into the bladder. Prognosis: 30% of the patients with crossed renal ectopia develop pyelonephritis or urolithiasis and 25% have hydronephrosis. Cystic disease. Cystic renal disease. Simple cysts are fluid-filled sacs which may be single or multiple and range in size, representing 70% of asymptomatic renal masses. They are mainly found in the renal cortex and do not communicate with the nephron or renal pelvis. This is in contrast to parapelvic cysts, which are simple parenchymal cysts found adjacent to the renal pelvis or hilum. Cysts may be bilateral and are increasingly prevalent with increasing age. There is no definitive etiology. The most common means of presentation is incidental diagnosis on imaging for another purpose. Acute presentations of severe pain can occur with bleeding into a cyst. As a result of the increased pressure from distension of the cystic wall. The differential diagnosis includes RCC, early autosomal dominant polycystic kidney disease, ADPKD, or complex renal cysts containing blood, pus, or calcification. A simple cyst requires no further treatment or follow-up in the rare situation where flank pain thought to be the cause. Options include percutaneous aspiration with or without sclerosing agent or surgical excision of the cyst wall. Pelvio-ureteric junction configuration or PUG. PUG obstruction is generally the result of a primary intrinsic defect of the ureteric muscular layers where there is an hyperostatic segment of ureter require a surgical treatment. Excuse me. Duplex system refers to a single kidney functionally divided into two parts, upper and lower, draining independently into two pelvically cell systems. Single system ureterocoele. Ureterocele represent a cystic dilatation of the terminal ureter into the bladder. The most adopted classification distinguishes the ureterocele into two types, orthotopic and ectotopic. An orthotopic ureterocele arises entirely from the normal location of its UO. It is contained within the bladder, but it can prolapse at the bladder neck or beyond. The ectopic ureterocele has part of its wall arising from an abnormal location, usually the bladder neck. Conservative management is an option in an asymptomatic child with a good to poor functioning upper parts draining into a non-obstruction ureterocele. Endoscopic ureterocele puncture has the advantage of the minimal invasive approach. Megaureter. Megaureter refers to an abnormal dilatation of the ureter with or without hydronephrosis. any dilatation of the retrovesical ureter more than 7 mm from the 30th week of gestation onward is considered abnormal. Megaureter can be classified pathophysiologically into four categories: obstructive, refluxing, reflux with obstruction, and non-reflux and non-obstruction. Oh yeah, this is megaureter. Retrocaval ureter is a rare entity where the course of the retrocaval ureter is a rare entity where the course of the ureter becomes posterior to the inferior vena cava at the level of L3-L4. Moderate to severe hydronephrosis with S or fish hook deformity of the ureter and the point of obstruction. The point of obstruction has some distance from the lateral margin of the IVC. Mild hydronephrosis with sickle-shaped curve of the ureter at the point of obstruction. The obstruction coincides with the lateral margin of the inferior vena cava. Retrocaval ureters requiring surgery are mostly treated by ureterostomy as approached open or laparoscopically. Yeah, and in this picture you see a hook, fish hook scene, retrocaval ureter. Bladder congenital anomalies, delayed for extrophy, Episparias complex, urachal anomalies, bladder diverticula and bladder ears, megacystis, and bladder duplication, septations, agenesis. Extrophy Episparias complex, Episparias. The failure of development of the lower abdominal wall during early fetal development is believed to give rise to a spectrum of abnormalities, which are described as extrophy Episparias complex. Three distinct anomalies comprise the complex: bladder extrophy, Episparias, and local extrophy. The pathogenesis is believed to depend on the stage of development when the local membrane ruptures. This premature rupture is attributed to the failure of the migration of the mesoderm between the layers of the endoderm and the ectoderm of the cloacal membrane. If the membrane ruptures before the completion of the urorectal septum's descent, the distal bowel, bladder, and urethra are not compartmentalized, giving rise to the anomaly of cloacal extrophy. Rupture of the membrane later on, after the separation of the urogenital and anal channels, is believed to lead to an open bladder and urethral plate. And if it occurs later in development, only the urethra and bladder neck remain open, giving rise to the Episparias anomaly, whereas there have been proposed to explain this embryological anomaly. However, it remains a source of controversy. Treatment: the primary bladder closure, lower abdominal wall, reconstruction and approximation of the pubic bones are generally achievable without osteotomies in early closure. For delayed closures, which is practiced in several centers across the world, or in cases with wide pubic diastasis, pelvic osteotomies with external fixators are needed. Inguinal hernias are repaired during this procedure when present. Complications after bladder closure include partial or complete wound dehiscence, a tight closure with outflow, obstruction, and upper tract dilatation, which in combination with UTI may lead to renal damage. Patient urachus, patent urachus. Their causes continuous or intermittent drainage of serosanguinous or purulent fluid from the umbilicus. If the umbilicus becomes infected, then there is periumbilical swelling, tenderness, and drainage. The diagnosis of a patient urachus can be done without ultrasonography and micturition cystogram. A patient urachus needs to be excised. The excision is done through an extraperitoneal approach, and the urachus needs to be excised completely, including a part of the bladder dome. This presents as a fluid-filled structure between the two obliterated ends of the urachus and is usually located in the distal third of the urachus. It is usually an incidental finding, or it can present as a suprapubic mass with fever, pain, and dysuria. In delayed diagnosis, the cyst may rupture towards the peritoneum causing acute abdomen and peritonitis. Bladder diverticula. They represent a herniation of the bladder mucosa through the detrusor. They can be congenital or acquired. Congenital diverticula are usually solitary and usually located near the ureteric orifice. Acquired diverticula are usually multiple. The diagnosis is set with ultrasonography, micturition, cystogram, and cystoscopy. Treatment is mandatory when diverticula are symptomatic, and it includes open or laparoscopic or vesicoscopic excision of the diverticulum with ureteric reimplantation where indicated. Megacystis. Megacystis refers to the presence of an usually large bladder. Bladder duplication. Bladder duplication is extremely rare. It can be partial or complete, with the duplication being in the sagittal or coronal plane. In complete duplication, there are two hemibladders usually in the sagittal plane, with the corresponding ipsilateral ureter draining within each hemibladder and in continuation with a duplicated urethra. Associated anomalies include a duplicated penis, duplicated vagina, and uterus. Vertebral anomalies, usually lumbar, and hindgut anomalies, often retrovesical, vesicovaginal, or vesicoureteral fistulae are present. Bladder Arginesis is extremely rare and incompatible with life. 23 cases have been reported in live births, and all were female infants. There you see anomalies with penis and urethra and prostate, and let's talk about them. Phimosis is the most common urological presentation in children. It is either primary or physiological or secondary or pathological. Lichen sclerosis, also commonly known as balanitis, xerotica obliterans. The foreskin is physiologically non-retractile beyond the glandular sulcus. In almost 100% of neonates, 50% by 1 year, and in most of the cases becomes retractile spontaneously. Given the natural history of phimosis in children, only symptomatic patients, particularly those with recurrent local infections or scarring, should undergo surgery. Before puberty is the absence of foreskin abnormalities or physical examination. Circumcision. The only absolute indications for circumcisions are secondary phimosis, paraphimosis, recurrent infections with scarring. Other indications include primary phimosis, recurrent balanoposthitis, and recurrent urinary tract infections in patients with urinary tract abnormalities, as these significantly reduce the bacterial colonization of the glands. Alternative to circumcision. Genital retraction of the prepuce. Many circumcisions can be avoided by counseling the mother. Gentle retraction of the prepuce may be at best time, could stretch the foreskin orifice, and help with maintaining the hygiene. Forceful preputial retractions should be avoided because it causes tear and hence scarring. Dorsal slit. A short vertical incision in the prepuce, the dorsal slit, just enough to allow the prepuce to be retracted fully, serves the same purpose, but the result is somewhat unsightly. Closing the incision transversely may be the answer. Paraphimosis is defined by acute swelling and inflammation of the distal penis and glands caused by a constriction ring of tight foreskin. You see it there. Paraphimosis is a medical emergency because delay in treatment can cause maceration of foreskin and even glandular ischemia, and then necrosis of head of penis. Episparias, by definition, implies that the urethral meatus is placed ventrally short of its normal terminal location. It can be located anywhere from the undersurface of the glands to the perineum, distal or anterior, glandular subcoronal distal penile, penile or middle, midshaft proximal penile, proximal or posterior, penoscrotal, scrotal, and perineal. It has three major components in various combinations: abnormal ventral opening of the urethral meatus, ventral curvature wholly of the penis, hooded foreskin with ventral deficiency. Indications for surgery include functional and cosmetic. Functional reasons include voiding, straight in standing position, sex and reproduction. More than 300 types of operations have been described in literature. General principles are: first, correction of Hordy; 2. Reconstruction of the urethra, urethroplasty; and 3. Skin cover. Episparias is defined as presence of urethral meatus along the dorsal surface of the penis. Treatment is surgery. Posterior urethral valves. The fetus develops in abnormal insertion of the Wolffian ducts into the urogenital sinus, leading to a parachute-like membrane across the prostatic urethra, exaggeration the folds that normally lead down from the verumontanum, attaching obliquely into the anterior urethra distal to the external urethral sphincter, cause a valve-like structure, and obstructing the outflow from the bladder. The posterior urethra is dilated and elongated. Physical findings may include distended, firm bladder, and a weak urinary stream. Abdominal distension as a result of a palpable distended bladder and hydronephrosis, urinary ascites, respiratory distress due to pulmonary hypoplasia. Management. Initial postnatal management involves good bladder drainage. This is usually accomplished with 6 French or an 8 French soft-feeding tube placed per urethra. Adequate care should be taken to ensure that the tube does not coil within the posterior urethra. Fluid and electrolyte management is critical in the initial period. After initial stabilization, endoscopic valve ablation or resection is the treatment of choice. Prostatic utricle is a small, blind pouch opening at the verumontanum. It is normally lined by glandular epithelium and has no function. It is considered by some to be the male homologue of the female uterus and vagina. Syringocele. Syringocele is a rare anomaly of the male urethra. It involves cystic dilatation of the main duct of the Cowper's glands, which can give rise to urethral obstruction or lower urinary tract symptoms like urinary frequency, urgency, dysuria, post-void incontinence, hematuria, or UTI. Described 4 types of Cowper's syringocele. Simple syringocele, in which there is reflux into a minimally dilated duct. Imperforated syringocele, in which the orifice draining the dilated duct is closed and there is cystic dilation of the distal duct at the level of the bulbal urethra. Perforated syringocele, third type. Perforated syringocele, in which the orifice draining the duct is patulous and there is free reflux into the duct resembling a diverticulum. Fourth type, ruptured syringocele, in which the distal portion of the duct is dilated but is not in communication with the more proximal portion of the main duct. Anterior urethral valves are composed of folds located on the ventral aspect of the urethra that co-op during voiding, resulting in urethral obstruction. They can be located in the bulbous urethra, penoscrotal junction, and penile urethra. It has been proposed that valves cause proximal urethral dilatation with the formation of a saccular diverticulum or a double-barreled urethra. Urethral duplication. Duplication commonly occurs along the sagittal plane. The ventral urethra is the more functional urethra and contains the verumontanum and sphincters. Effman classified urethral duplication into 3 types. First type, partial duplication of the urethra. Type 2, complete duplication of the urethra. 2A1, both urethral arise separately from the bladder. through A2, one channel rises from the other. Double duplication occurs when one urethra arising from the bladder, neck, or posterior urethra opens to the perineum. This type of urethral duplication often coexists with stenosis or the anterior portion of the normally positioned urethra and other severe congenital anomalies. 2b. Duplication with one meatus. And type 3, complete duplication of the urethra and bladder. Depending on the type of duplication, patients might be asymptomatic. Symptoms include UTI, epididymitis, and incontinence. Surgical excision of the duplication is mainly reserved for recurrent symptoms. An ambiguous genitalia is a phasing out terminology and general term used to describe any deviation from the normal appearance of the external genitals. DSD originate from the following underlying mechanism: chromosomal defects, abnormalities of gonadal development, defects in the synthesis of sex hormones or relevant receptor, for example, phenotypic or anatomical DSD. 46. XY-DSD, previously male pseudohermaphroditism, disorders of testicular development, complete and partial gonadal dysgenesis, disorders of androgen synthesis, complete and partial androgen insensitivity, disorders of anti-Mullerian hormone, receptor androgen biosynthesis results in various degrees of feminization. Other severe Episparias, cloacal extrophy. Semenia, you see a girl, yeah, or man, sure, its name, Semenia, is an intersex cisgender woman, assigned female at birth, with XY chromosomes and naturally elevated testosterone levels, due to 5-alpha reductase deficiency. Disorders of ovarian development, testicular DSD, and gonadal dysgenesis, androgen excess, fetal adrenal hyperplasia, fetoplacental, maternal, and others, DSD, vaginal atresia, cloacal extrophy. It's symptoms of 46 XXDSD. Sex chromosome DSD you see on the slide. Turner syndrome, you can see on the slide, yeah, and then you need to understand that we have XO without X and without Y. Klinefelter syndrome, you can see these signs on the slide. XXY. Cryptorchidism. Understanding testes is a common finding in treatment is based on the location and presence of the testicles. Ectopic palpable testicles require surgery. A retractile palpable testicle should be watched closely until puberty in case it returns to the abdomen. If both understanding testicles are non-palpable and sexual differentiation problems exist, and an chronological and genetic evaluation should be done. Boys and the majority of cases have no discernible etiology. And that's all for today. Thank you for your attention and have a nice day. Bye bye.